Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels almost like engineering, right?
Right. It feels totally binary.
Yeah, exactly. I mean, you fall off your bike, you break your arm, the X-ray shows that jagged white line on the screen, and the doctor just points and says, there it is.
We crave that certainty. We really like things to be visible, to be categorized, and most importantly, we like to know there's a linear path to fixing it.
But then you step out of that individual exam room, and you zoom out to the macro world of modern healthcare systems, and suddenly
Everything gets complicated.
everything. You start looking at the unseen operational threats, the administrative bottlenecks, the invisible biological hazards just lurking within the buildings themselves.
Yeah, and suddenly that clean X-ray machine is broken. We're looking at a landscape that is just profoundly murky.
So for the learner listening right now, I want you to imagine a scenario for a second. Think about the last time you or a loved one had a medical emergency.
A terrifying thought for anyone, really.
Right. But what if the very place you go to get healed, the place you rush to in a moment of sheer panic, is actually the place most likely to make you incurably sick?
Oh, wow. I mean, that is the absolute definition of a systemic paradox. The sanctuary essentially becomes the hazard.
Exactly.
And, it doesn't happen overnight. It happens through this really slow, compounding series of structural failures.
And that systemic paradox is exactly what we're digging into today.
Yeah.
We have an absolute mountain of information to synthesize for you.
A massive stack.
Seriously, we're looking at huge NHS financial reports, specifically diving into the granular data from 2025 and 2026. We're cross-referencing that with epidemiological studies on antimicrobial resistance, or AMR. We have the definitive 2026 UK Health Waiting List Crisis Report.
Which is a heavy read, to say the least.
Oh, it's brutal. We're even analyzing legal documents from some incredibly intense historical whistleblowing cases to, really understand the liability pressures on the system. And finally, we're parsing this deeply detailed technological blueprint for a new AI triage infrastructure called the Prema Kiosk, which is powered by Dr. Maya AI.
It is a vast array of interconnected data. I mean, we are moving from the microscopic reality of like a single bacterium on a waiting room chair all the way up to the macroeconomic deficits of an entire national health service.
Okay, let's unpack this, because we really need to set the stage properly. Our mission for this deep dive is to decode what looks like the real-time mathematical collapse of traditional healthcare systems.
Using the UK's National Health Service, the NHS, as our primary model.
Exactly. And then we're going to critically examine this proposed technological blueprint that claims it can pull the NHS back from the brink of financial and operational ruin.
The overarching argument we're analyzing today is that this AI infrastructure could not only save the domestic system, but actually position the NHS as a global health leader.
Wait, like bypassing the World Health Organization entirely?
Potentially, yes, bypassing the traditional surveillance models of organizations like the WHO.
Which is a staggering ambition.
It is. But when you map the data points provided in this blueprint, they don't just offer political rhetoric. They lay out a very specific mathematical and clinical pathway to that exact outcome.
Because we're essentially dealing with a severe chronological mismatch, right?
How do you mean?
Well, we have 21st century cutting-edge medical science. I mean, we can edit genes, we can perform robotic surgeries.
Right. Incredible advancements.
But that science is entirely bottlenecked by a mid-20th century administrative structure.
Oh, absolutely.
We're trying to run a modern high-demand population through an intake system that was designed decades ago. And the cracks aren't just showing.
Well, walls are actively coming down.
They really are. When you analyze the 2026 Waiting List Crisis Report, you aren't just looking at a system under stress.
No, you're looking at a system that has completely surpassed its breaking point. This isn't about, a few delayed routine appointments anymore.
Or having to wait an extra week to see a knee specialist.
Right. We're talking about statistical realities that translate into a staggering, almost unquantifiable human toll.
The numbers are genuinely hard to wrap your head around. Just to give you a sense of scale, the 2026 report outlines that there are 7.31 million cases on the elective care backlog in England alone.
7.31 million cases.
Yeah. Now, because some people need multiple treatments, that equates to 6.19 million unique individuals.
Wow.
I really want you to think about that number. That is a population larger than many European countries.
Just sitting there in a state of suspended animation.
Exactly. Waking up every day, managing pain, managing anxiety, unable to fully participate in their lives or the economy, just waiting for a planned hospital treatment.
And the psychological impact of that suspended animation, as you called it, is just immense.
It has to be.
But when you correlate that human backlog with the concurrent financial hemorrhage, the picture becomes deeply, deeply unsustainable.
The money side is wild. The NHS is facing a projected annual deficit of £6.4 billion for the 2024-2025 period.
6.4 billion.
Yeah. And to see what that looks like on a granular local level, I was poring over the NHS Highland Month 8 finance report.
Oh, that's a very telling document.
It is. Just in that one specific regional board, they reported a £17.131 million overspend year to date.
Right.
And it's easy to just throw around millions and billions, but when you look at why they're overspending, it reveals the core rot in the operational model.
Where was all that money going?
Out of that £17 million overspend, $16.22 million was driven entirely by supplementary agency staffing.
Wow. See, that is the critical diagnostic marker of a failing operational model.
Just bleeding money on temps.
Exactly. The system is entirely reliant on these temporary fixes, these highly paid agency staff, just to plug the holes caused by chronic workforce shortages, long-term vacancies, staff burnout.
Well, let's break that down for someone who doesn't work in healthcare finance. Why is agency staff so much more expensive than regular staff?
Well, when a hospital or a clinic can't fill a shift with their own salaried staff, they have to turn to private staffing agencies.
Makes sense.
But these agencies charge a massive premium. You aren't just paying the nurse or the doctor their standard hourly wage.
Right, the agency has to make money too.
Exactly. You're paying the agency's profit margin, their administrative fees, and often surge pricing for last-minute cover.
Like Uber surge pricing, but for a trauma surgeon.
Precisely. And nationally, this dependency on temporary agency staff cost the NHS a staggering £3.5 billion.
$3.5 billion just on temporary staff. That's insane.
It is an incredibly inefficient way to run any enterprise, let alone a critical public health service. You're bleeding premium rates just to keep the lights on and maintain baseline safety.
Right. You're not even using that money to actually reduce the $7.31 million backlog. You're just treading water.
Exactly. It's a vicious cycle. You overspend on agency staff, which blows a massive hole in your budget.
And because your budget is blown, you can't afford to hire full-time staff or improve the working conditions.
So your existing staff burns out and quits.
Which creates more vacancies, which forces you to hire more premium agency staff.
It's a complete financial death spiral.
And a huge part of why that staffing pressure is so intense, why everyone is so overwhelmed, is because the front door to the entire system is fundamentally broken.
And when we say the front door, we're talking about the primary triage system.
Right. Specifically NHS 111 and primary care receptionists.
Yes. Because if you feel sick, your first instinct isn't usually to barge right into an operating theater.
No. You call NHS 111 or you call your local general practitioner surgery.
So what is happening at that crucial first point of contact? What's fascinating here is how the structural failure of this initial contact point creates a dangerous cascade.
A cascade that just floods the rest of the ecosystem.
Exactly. The reality of the current model is that the people manning this front door often lack any formal clinical background.
I was absolutely shocked reading this part in the sources.
It's alarming.
We're talking about call handlers and GP receptionists who, in some documented cases, are literally teenagers or entirely untrained administrative staff.
Sitting in a call center or behind a desk, relying entirely on rigid, algorithm-driven decision trees on a computer screen.
Right. A patient calls up, panicked, describing a symptom, and this untrained operator is trying to figure out if, chest pain is indigestion from a spicy curry or a widowmaker heart attack.
And this highlights the core psychological and operational flaw.
Which is?
Because these operators lack clinical confidence, deep medical intuition, and, well, years of diagnostic experience, they cannot safely differentiate between a mild self-limiting illness and a severe life-threatening one.
I mean, how could they? They haven't gone to medical school.
Exactly. And more importantly, they're completely unequipped to take on the liability of telling a patient, you're fine, just stay home, take some paracetamol, and drink water.
Think about it from the operator's perspective. You're making near minimum wage. You have a terrified mother on the phone saying her baby feels unusually hot.
Right.
You don't have medical training. Are you really going to risk a child's life? and your own job
Yeah.
and potentially face legal action by telling her to just wait it out?
Of course not. You'd never take that risk.
Exactly. To use an analogy, the current triage system is like a club bouncer who have been told to guard the VIP room, but nobody ever handed them the guest list.
Oh, that's a great way to put it.
Right. And because they're absolutely terrified of accidentally turning away the owner of the club or some celebrity and getting fired on the spot, they just let everyone in.
They just shove every single person who walks up to the door straight into the VIP room.
And eventually the floor of that VIP room just collapses under the sheer weight of the crowd.
So in healthcare terms, they funnel everyone who calls, regardless of acuity, straight into the GP waiting room or the accident and emergency department, the A&E.
Exactly. It's a brilliant, terrible system.
Well, they are incentivized to play it safe at the micro level. But playing it safe on an individual call level translates to catastrophic overload on a systemic level.
You end up with massive amounts of wasted, highly specialized consultation time.
The operational analysis we reviewed estimates that 30 to 40% of the contacts currently ending up in A&E or GP surgeries could actually be safely managed at home.
40%.
Yes, handled at home by a pharmacist or without seeing a doctor at all. Yet, because the front door cannot safely filter them out, they're all being pushed into those same overloaded, highly expensive funnels.
And this brings up a deeply complex and honestly intense layer of our deep dive.
Yeah.
The medical legal nightmare.
The huge factor.
Because this over-triage isn't just about inefficiency or a lack of medical knowledge. It's fundamentally driven by a fear of liability.
Yes, the fear of getting sued is massive.
We're looking at historical whistleblowing cases that show exactly how deep this tension goes between a system trying to save money on triage staff and the immense patient safety risks that creates.
The historical documentation provides extensive details on the case of Dr. Srivatsa. This unfolded around 2006 and 2007, involving an out-of-hours service called Thames-Doc.
Okay, before we get into the details of that, I want to establish a very clear parameter for our discussion here.
Please do.
As we examine this case, we are strictly looking at the documented legal claims, the court proceedings, and the systemic pressures they highlight. We are completely impartially reporting the contents of these public records to understand the wider historical context of primary care liability.
Right, absolutely. We are not taking sides in that specific legal dispute.
No, absolutely not. We're not endorsing the viewpoints of any party involved. We are simply utilizing this documented case study to illustrate the immense pressures the NHS environment was operating under.
Understood. So, based on the records, Dr. Srivatsa formally documented and blew the whistle on a specific operational practice.
What did he find?
He raised concerns that nurses with no formal medical qualifications to diagnose patients were being placed onto doctors' duty rotas.
Wait, nurses acting as doctors?
Yes. They were put in positions to offer emergency, out-of-hours advice to patients, essentially acting in the capacity of doctors, despite the fact that some reportedly hadn't even worked in intensive or critical care environments.
So he raised the alarm that this specific model, which the documents describe as doctor-centered but staff-filtered, represented a massive systemic risk to patient safety.
Because unqualified staff were making critical clinical decisions primarily as a cost-saving measure.
You were asking people without the diagnostic training to make life or death judgment calls.
Exactly. And the professional fallout from him reporting this was allegedly severe.
Yeah, the legal claims detailed retaliation, harassment, and unlawful removal from the performers group list in 2010.
Which escalated into a massive multi-year legal battle against the Secretary of State for Health involving claims of unlawful discrimination and unfair dismissal.
And what makes this case fundamentally crucial to our understanding of the modern NHS crisis is the legal concept it hinges on: vicarious liability.
Vicarious liability. This is the cornerstone of employment law, where employers, in this case the healthcare system, are held legally and financially responsible for the mistakes, negligence, and wrongdoing of their staff.
Right. So if a receptionist, an untrained 111 operator, or a nurse acting outside their diagnostic scope makes the wrong call and a patient dies, the liability doesn't just fall on that individual.
No, it falls on the entire system.
The financial exposure for this system is astronomical. And in Dr. Srivatsa's case, the documents quote Lord Justice Lewison from the Court of Appeal.
What did the judge say?
He explicitly noted that the Secretary of State attempted what he called a neat technical swipe to try and eliminate Dr. Srivatsa's substantial claim without even allowing a tribunal to hear the full evidence.
Wow.
The court ultimately allowed the appeal to go to trial, And again, we're just reporting the mechanics of the legal battle as detailed in the records, but it illustrates a profound point.
Which is?
Institutions face immense existential legal threats when managing these liabilities. The lengths they will go to mitigate or dismiss these claims highlight just how dangerous vicarious liability is to the system's survival.
It creates a perfectly paralyzed system. I mean, they use unqualified staff at the front door because they can't afford enough doctors.
Yeah.
But that exposes them to massive legal risks and vicarious liability. So to mitigate that immense legal risk, they instruct the unqualified staff to over-triage, sending everyone who calls straight to A&E to ensure a real doctor sees them.
It's a vicious cycle, driven just as much by the fear of litigation and multi-million-pound payouts as it is by actual health concerns.
Exactly.
Which brings us to a reality that I found to be the most terrifying part of this entire analysis.
Even more terrifying than the bankruptcy.
Oh, definitely. This constant fear-driven funneling of millions of terrified, unsorted patients into A&E departments and crowded GP surgeries doesn't just waste billions of pounds.
Right.
It doesn't just burn out the doctors. It creates a physical, biological environment that is actively breeding the next global catastrophe.
You're referring to antimicrobial resistance, or AMR?
The quiet apocalypse.
Yes. In the context of the epidemiological literature we reviewed, it is often characterized exactly like that, the quiet apocalypse.
The silent tsunami. I mean, we hear constantly about the waiting lists, the financial deficits, the strikes, but AMR is the invisible monster hiding right under the waiting room chair.
It really is.
If you're listening to this, you might have heard of antibiotic resistance, but what is the actual statistical reality of this crisis right now?
The statistics are undeniably grim. Currently, AMR, which encompasses infections caused by bacteria, viruses, fungi, or parasites that have evolutionarily adapted to resist the antimicrobial drugs designed to kill them, is directly responsible for killing 700,000 people globally every single year.
700,000 people?
Every year. And these are infections that a decade ago would have been easily treated with a standard course of antibiotics.
But the projections are where the true scale of the threat really emerges, right?
Yes. The World Health Organization, alongside numerous independent epidemiological models, projects that without a massive, decisive intervention in how we manage healthcare environments, AMR will kill between 10 and 16 million people annually by 2050.
10 to 16 million people a year.
It's staggering.
That means within a few decades, superbugs will overtake cancer as the world's leading killer.
Exactly. We are talking about a potential return to the dark ages of medicine,
where a simple scratch from gardening or, a routine C-section becomes a death sentence.
Yeah.
Because we just have no drugs left that work.
It's a terrifying prospect.
There is a quote in one of the clinical analyses we reviewed that gave me absolute chills. It says, "It's not a place of healing, it's a distribution center for superbugs."
Wow.
And they aren't talking about a meat processing plant or a sewer. They are talking about the modern hospital.
Yes. The hospital, and specifically the high-density waiting room, essentially acts as an exposure dose multiplier.
We culturally perceive hospitals as sterile, safe environments, though. Like, we go there to get clean and get well.
We do, but let's connect this back to our front door problem. When you have NHS 111 unnecessarily sending mildly sick people to A&E because of the triage failures we just analyzed.
Right, the bouncer without the guest list.
Exactly. Those people don't go into a vacuum. They go and sit in a crowded room right next to highly vulnerable people, the elderly, the immunocompromised, or people who are already carrying highly resistant pathogens.
And the mechanics of how this spreads are vital to understand. I think a lot of us still operate under the assumption that you only get sick if someone visibly ill coughs directly into your face.
Right, the direct transmission myth.
But the data highlights the sheer danger of indirect transmission.
Precisely. Prolonged wait times are frequently framed as a logistical inconvenience or, a political talking point, but biologically, prolonged wait times are a primary clinical risk factor.
Because you're just sitting in it.
Yes. The longer a patient sits in the stagnant air and the high-density, high-stress environment of a waiting room, the higher their statistical probability of encountering a resistant pathogen. The bacteria don't need a direct sneeze, they hitchhike.
Let's drill down into the actual data on this, because the 2023 Anaja National University study included in our review is mind-blowing.
It's a landmark study for environmental contamination.
They didn't just model this on a computer. They went into active hospital environments and aggressively swabbed and tested the surfaces.
Right.
First, we need to establish the baseline, the universally accepted safe limit for surface contamination, The threshold before a surface is considered a significant infectious risk to a patient is 1 CFU per square centimeter.
Right. 1 CFU.
That stands for colony-forming unit.
A colony-forming unit is essentially a measure of viable bacterial or fungal cells capable of multiplying. If you are under 1 CFU per square centimeter, the risk of transmission is generally considered manageable.
Okay, so 1 is the limit. But the findings from the NHS study, particularly in high-traffic areas like the radiology department, were deeply alarming.
What did they find?
When they swabbed the size of patient tables used for CT and MRI scans, the contamination levels hit 20.0 CFU per square centimeter.
20.0. Wow, that's 20 times the safe limit.
Exactly, where you lay your head or where you grip the table when you're nervous about the scan.
Exactly. And it extended to the equipment the staff interacts with constantly, too.
Oh, yeah. Keyboards in the control rooms hit 8 CFU per square centimeter. Patient leg supports hit 8.0. They were vastly, consistently exceeding the established safe limits.
And I want to be very clear for the listener, this is not just harmless dust or normal skin flora.
No, definitely not.
The specific pathogens they identified flourishing on these surfaces are lethal. We're talking about MRSA, which can rapidly cause sepsis and destroy heart valves.
Terrifying.
VRSA, which is vancomycin-resistant Staphylococcus aureus. Vancomycin is heavily relied upon as a drug of last resort when other antibiotics fail. If a bug is resistant to vancomycin, the medical toolkit is virtually empty.
You're just out of options.
And they also found VRE, which frequently leads to catastrophic bloodstream infections.
When I read this, my immediate thought was, how on earth does a modern hospital get this contaminated? I mean, if you walk into any A&E, you constantly see the custodial staff working.
Right, they're always mopping.
They're mopping, they're wiping things down.
Yeah.
How do these superbugs survive the cleaning protocols?
The failure of the cleaning protocols is directly tied to the systemic overload we discussed earlier.
The backlog.
Exactly. As the patient workload spikes, driven by that broken, fear-based triage funneling thousands of unnecessary cases into the building, the efficacy of environmental cleaning completely collapses.
They just don't have time.
The study makes a definitive point that the current operational standard of morning-only deep cleaning is an absolute failure in a modern, hyper-busy hospital.
Because it doesn't matter how sterile the room is at 6 a.m. if you run 50 sick people through it by noon.
Precisely. The document points out a direct, undeniable correlation between patient workload and contamination levels.
I saw that. In June, when patient referrals to the radiology department spiked, the bacterial counts on the equipment spiked right along with them in perfect synchronization.
Consider the physical reality of the workflow. When a CT scanner or a clinical examination couch is being used back-to-back across a massive, highly diverse patient population, the staff simply do not have the adequate downtime required to perform a deep chemical disinfection between every single patient. The turnaround demands are just too high.
They'd never get through the line of patients.
Exactly. Consequently, the silent reservoir of pathogens expands continuously throughout the day.
And it's not just the large, obvious machines either.
No.
The study notes that these lethal pathogens hitchhike on incredibly mundane items. Unsterile gloves stored in open boxes on the wall.
Right.
The plastic bibs and gowns worn by asymptomatic carriers who don't even know they're shedding bacteria. Even the informational magazines left scattered on the tables in the waiting room become vectors for VRSA.
Oh, that is a horrifying visualization.
Seriously, imagine you're a parent. You go to the A&E because your teenager has a weird rash that the 111 operator got nervous about.
Because the operator has no clinical training.
Exactly. So you sit in that waiting room for 4 hours because the backlog is huge. Your kid is bored, so they pick up a magazine that a dozen other sick people have touched that day, and suddenly they have just physically interacted with a vancomycin-resistant superbug.
Oh.
They came in for a minor rash, and they could leave with a deadly bloodstream infection.
And the psychological element, how humans behave when they are sick, just adds fuel to this biological fire.
Right, because human behavior in healthcare is deeply driven by fear and avoidance.
The epidemiological sources note that the fear of a severe diagnosis, like cancer or a chronic disease, frequently causes patients to delay seeking help initially.
They put it off.
Exactly. They ignore the early symptoms, they stay out in the community, moving through supermarkets and public transport, shedding resistant bacteria if they happen to be colonized.
And then inevitably the symptom worsens, the panic sets in, and they rush to the hospital.
And often they rush to the hospital unnecessarily for a minor flare-up, but they enter this high-density ecosystem carrying whatever bugs they've incubated.
The text points out a terrifying statistic. Up to 83% of the people in that specific hospital environment might be colonized with some form of resistant bacteria at any given time.
83%.
It is a trap. If the waiting room is the biological trap, and the human triage via NHS 111 is the funnel pushing you into that trap.
The logic seems inescapable.
Right. The only way to save the healthcare system from financial ruin and to save the population from the AMR apocalypse is to intercept the patient before they ever cross the threshold of a hospital.
You have to intercept them in their own community.
That is the exact fundamental thesis of the proposed solution outlined in our sources.
You have to achieve two things simultaneously. You must break the physical chain of bacterial transmission, and you must relieve the systemic triage pressure.
And that brings us to the core of the technological blueprint we are evaluating, the Prema Kiosk.
Okay, I want to drill down into this.
Because whenever someone says they have a tech solution for healthcare, my immediate reaction, and probably the listener's reaction, is to roll our eyes.
Absolutely. We instantly think of another clunky, frustrating app that we have to download on our phone.
That requires 3 passwords, crashes half the time, and ultimately just tells us to call our doctor anyway.
Right.
But Prema, which stands for Personal, Responsive, Empowering Medical Assistance, is not just another app on an app store. Here's where it gets really interesting.
The blueprint is adamant that this requires physical infrastructure.
Yes. The Prema system is a standalone IoT-enabled healthcare kiosk. Conceptually, think of it as the highly advanced modern successor to the traditional public telephone booth.
It is designed as deployable street furniture.
They're proposing putting these physical booths in local pharmacies, outside supermarkets, at 24-hour petrol stations, and right in the center of rural villages.
That's incredible access.
And crucially, looking at the engineering specs, these kiosks run on solar panels. They do not require hardwired electricity, and incredibly, they do not require cellular networks or Wi-Fi to function.
Wait, let's pause there. I want to push back on this for a second.
Sure.
You have an AI that is supposed to be diagnosing patients, but it doesn't need the internet. How is it analyzing anything? Is it just a glorified flowchart stored on a hard drive?
That's a vital question regarding the architecture. It's not a simple flowchart. The system utilizes what's known as edge computing.
Edge computing?
Yeah. The core intelligence of Dr. Maya AI is localized on the machine's internal hardware itself, allowing it to process natural language, recognize symptom patterns, and run complex algorithmic assessments without needing to ping a cloud server in real time.
Oh, I see.
For data synchronization like updating patient records or receiving software patches, it can utilize asynchronous data bursts via satellite or low-bandwidth networks like LoRaWAN when a connection becomes intermittently available.
So it processes locally and syncs globally when it can.
Exactly. Okay, that makes sense technically, but why is that hardware aspect so important? In 2026, why go through the massive expense of building and deploying physical solar-powered steel boxes?
Yeah, why not just make the Dr. Maya AI a really good smartphone app and save millions on manufacturing?
The answer lies in accessibility and the stark reality of the global digital divide.
Right, not everyone has a smartphone.
Exactly. The business plan highlights demographics that are entirely excluded from the current telemedicine revolution. To put it in perspective, the sources cite that in India alone, there are 760 million people who do not own smartphones.
760 million.
There are 287 million illiterate adults globally. And even in highly developed nations like the UK, there are an estimated 104 million elderly people globally who are simply uncomfortable or physically unable to interact with complex digital technology.
Right. You cannot reasonably ask an 85-year-old man living alone in a rural village who thinks he might be having a stroke to pull out a smartphone, navigate a multi-factor authentication login, remember his password, and type his symptoms into a 5-inch touchscreen with shaking hands.
It is a recipe for disaster.
But that raises another viability question. Okay, the physical kiosk is there at the petrol station. But what makes us think that same 85-year-old is going to trust a glowing monolith to tell him about his health? How do they actually interact with it?
The design philosophy of the kiosk is heavily focused on overcoming that exact friction. The interface is not reliant on typing.
Oh, good.
It features a highly visual, icon-based touchscreen combined with sophisticated voice guidance that operates natively in multiple regional languages.
So they just talk to it.
Yeah. A patient can simply walk up to it and speak naturally about what is bothering them, just as they would to a human receptionist, but without the judgment, the rush, or the cue.
So someone walks up, the kiosk wakes up, and they say, my chest feels tight and I have a fever. How does the Dr. Maya AI actually process that triage? What is the output.
The AI operates on a proprietary, highly trained symptom pattern recognition methodology. The goal is to replace the hesitant, liability-fearing human receptionist we discussed earlier with a decisive, consistent clinical intelligence.
It processes the patient's inputs and outputs a definitive, color-coded categorization.
Let's walk through those color codes because this seems to be the core of how it stops the A&E bottleneck.
It breaks down into 4 clear directives. Red means emergency. The AI has detected a potentially life-threatening condition based on the symptom matrix. The kiosk will instruct the patient to call 999 immediately, and in some iterations, can initiate that call.
Okay, so red is immediate danger.
Yes. BLUE signifies an infection risk. This flags a potential need for antibiotics. The directive is to see a GP or a prescribing pharmacist within 24 hours.
Got it.
Yellow indicates self-care. The system determines the condition is benign and provides immediate on-screen guidance for managing the symptoms safely at home.
That's huge. And green.
And finally, green means safe. No immediate medical intervention is required. The symptoms are normal physiological responses.
By giving a patient a definitive, safe, color-coded answer, you instantly dismantle that fear-driven reliance on the emergency room.
Because when you are sick, you lose your objectivity.
Completely. You just want an authoritative adult in the room to tell you what to do. If an AI, which the documents state is trained on 50 years of clinical experience and vast data sets, tells you your symptom is definitively green, you go home and go to bed.
It takes the diagnostic guesswork completely away from the untrained teenage receptionists.
And crucially, it stops the terrified patient from getting in their car, driving to the hospital, and walking into that superbug distribution center we just talked about.
Precisely. It breaks the chain of transmission and relieves the system simultaneously.
And what's particularly compelling is how this technology addresses a very specific, deeply ingrained pattern of user behavior.
The late-night panic.
Yes. The pilot data from early integrations of the Dr. Maya app provides a fascinating window into when people panic. The data showed that 73% of all consultations happen in a very specific window, between 8 p.m. and 2 a.m.
Ah, the late-night panic window. If you are a parent, you know this exact feeling in your bones.
Oh, absolutely. Your child wakes up at midnight, burning up with a fever, crying inconsolably. The GP surgery has been closed for 6 hours.
You're exhausted, you're terrified, and your rational brain turns off.
You call NHS 111, and the automated voice tells you there's a 45-minute wait just for a call back from a triage nurse. What do?
You don't wait. You wrap the kid in a blanket, put them in the car, and you drive straight to the emergency room, adding to the backlog and exposing your child to AMR pathogens.
That is the exact behavioral loop the system is trying to short-circuit. With a Prema Kiosk located at the local 24-hour petrol station or the corner pharmacy, that parent has an immediate alternative.
They drive 2 minutes down the road, interact with the kiosk, and get a clinical assessment in under 60 seconds.
60 seconds.
They find out immediately if that fever is a red emergency or a yellow self-care situation.
And the demographic data strongly supports its usability. In the initial UK pilot studies, 78% of patients over the age of 70 were able to use the kiosk interface successfully within their first 2 attempts.
It provides immediate authoritative reassurance when people are most vulnerable.
But, and I think this is crucial to emphasize for anyone listening who works in healthcare, we need to be very clear about what this blueprint explicitly states the technology does not do.
Yes, that's a very important distinction.
We're not talking about a robotic doctor performing appendectomies in a petrol station?
No, the technical documentation is extremely explicit regarding its clinical boundaries, largely to reassure skeptical medical professionals and regulators.
What are the boundaries?
The Prema Kiosk does not formally diagnose complex conditions without human GP oversight. It absolutely does not prescribe controlled medications or antibiotics autonomously.
Okay, good.
And it is not designed to replace face-to-face consultations for complex multimorbid cases where a human doctor needs to physically examine a patient.
It is an intelligent, highly efficient filter. It's designed to skim off that 30 to 40% of the patient volume. The people who just need reassurance, basic self-care advice, or a routine repeat prescription.
The people who absolutely do not need to be taking up a valuable 10-minute GP slot or sitting in an A&E waiting room for 6 hours.
In essence, it extends the general practitioner's authority and reach into the community, rather than bypassing it.
It handles the routine, algorithmic noise, which allows the highly trained human doctors to spend their actual time and cognitive energy on the complex cases that require human empathy and intuition.
Okay, conceptually, this sounds phenomenal. An AI health booth on every corner that tells you if you're dying or if you just have a cold, saving you a trip to the superbug ward.
It's a very elegant solution.
But I have to bring us back to the brutal reality of the spreadsheets we looked at earlier.
The money.
The money. The NHS is running a £6.4 billion deficit. We just discussed how they are overspending by $17 million in a single region just to staff the crumbly buildings they already have.
Right.
How on earth does a bankrupt system afford to purchase, install, and maintain a nationwide network of thousands of highly advanced AI kiosks? I mean, the upfront capital expenditure must be astronomical.
That is the pivotal question for any decision maker, and it's where the economic modeling in these business documents becomes highly persuasive.
Lay on me.
We have to look at the comparative math because the cost differential between the current human-driven infrastructure and the AI infrastructure is staggering.
Let's look at those numbers. What does it actually cost the NHS every time a patient interacts with the system today?
The current estimated cost per patient contact for standard accident and emergency attendance is £168.
£168 just to walk in the door.
If a patient goes to a localized walk-in center instead, it costs the system £57 per contact.
Yeah.
A standard 10-minute GP consultation costs the system £39. And even the most basic interaction, a phone call to NHS 111 that we established is often handled by untrained staff, costs the system between £18 and £22 per call.
Just to maintain the call center infrastructure and staff wages.
Exactly.
Okay, so £168 at the high end for A&E, down to roughly £20 for a phone call. What is the projected cost per interaction for a patient using the Prema Kiosk?
The projected operational cost is between £3 and £5 per interaction.
£3 to £5. That is practically a rounding error compared to the A&E cost.
It's a fraction of even the cheapest current option.
Yes, and the business plan breaks down the deployment return on investment, the ROI, very clearly. A single Prema Kiosk costs approximately £2,500 to £5,000 to manufacture and install, depending on the specific location requirements.
Right.
Now, if that kiosk sees just 10 paid consultations a day, which is an incredibly conservative estimate given the 7.31 million backlog and the massive daily demand for primary care, at £5 per consultation, it generates £18,250 a year in gross revenue or equivalent value.
Wait, I want to make sure I'm doing this math right. You are saying a machine that costs £5,000 to install pays for its own capital expenditure in a matter of months, just on a minimal baseline usage of 10 people a day.
Exactly. According to the pilot data included in the blueprint, the investment recovery periods average between 5 to 7 days of operation in certain high-traffic, high-demand locations.
5 to 7 days.
The machine pays for itself almost immediately. But the real macroeconomic value to the NHS isn't the direct £5 revenue. It's the massive avoided costs elsewhere in the system.
Right, it's the avoidance of that £168 A&E bill. Every time the kiosk gives someone a green or yellow code, the NHS just saved £168.
Precisely. The macroeconomic projections suggest that deploying 10,000 kiosks nationally over a 3-year period would successfully divert between 15 and 25 million contacts away from GPs and A&E departments.
That's massive.
The direct measurable savings to the NHS budget are estimated to be between £400 million and £700 million annually.
Wow.
And if they scale the network to 20,000 kiosks, the annual savings easily surpass £1 billion.
When you really think about the hidden costs of our current model, it makes total sense. If you triage a patient through an AI kiosk, you are entirely eliminating the massive overhead of physical real estate.
No more waiting rooms.
Exactly. You don't have to rent a massive building for a waiting room. You don't have to pay to heat it in the winter. You don't have to outfit hospital infrastructure or pay custodial staff to try and scrub VRSA off the chairs.
And crucially, circling back to the NHS Highland report we looked at earlier, you do not have to pay that $16.22 million in premium surge-priced agency staff rates just to have a human being tell someone they have a runny nose.
The economic bleed is stopped right at the source.
And beyond the direct operational costs, the kiosk network provides a definitive solution to the medical legal nightmare we discussed with the Dr. Srivatsa case.
Oh, the vicarious liability.
Yes. By replacing stressed, fatigued, unqualified human operators with a standardized AI-driven assessment tool like Dr. Maya AI, you drastically reduce the system's exposure to clinical negligence claims.
Why does AI solve the vicarious liability problem? I mean, if the AI makes a mistake, isn't the system still sued?
The nature of the liability changes entirely. The AI doesn't panic. It doesn't suffer from cognitive fatigue at the end of a 12-hour night shift. It doesn't get intimidated by an aggressive patient. It applies the exact same rigorous clinical logic to the first patient of the day as it does to the 1,000th.
And crucially, from a legal defense standpoint, there is a perfect, immutable, auditable digital trail for every single triage decision it makes.
Right. If an outcome is ever questioned, the logic pathway, exactly why the AI gave a yellow code based on the specific inputs, is entirely transparent.
Which provides a massive data-driven shield against the kind of messy he said, she said, vicarious liability claims that arise when human receptionists make undocumented verbal judgment calls.
That auditable trail is huge for the administrators. But what about the doctors themselves? It seems like there is a massive first-mover advantage here for the general practitioners who adopt this tech early.
Oh, absolutely. The documents contain pilot data from GP practices that integrated the kiosk triage, and the results are pretty dramatic.
Tell me about it.
They are highly compelling for the workforce. In a 6-month UK pilot program involving a GP practice of 8,000 patients, the average wait time for a routine appointment dropped by 50%. It's cut in half.
Going from an 18-day wait down to just 9 days. Furthermore, admin-only appointments, which are patients taking up doctor time just to ask for test results, or a routine sick note dropped by 66%.
So the AI handled the administrative load.
Exactly. And the human impact on the doctors is measurable. The GP burnout scores, which were measured on the recognized Maslach scale, dropped from 38, which is considered high, dangerous burnout, down to 21, it was manageable, moderate burnout.
That's a life-changing difference for a physician.
GP daily administrative hours went from 3.2 hours a day down to 1.1. They got 2 solid hours of their life back every single day.
The strategic argument made in the sources is quite aggressive on this point. GP practices that refuse to adopt this technology will face an inevitable patient exodus.
I mean, they will.
Once patients realize they can register with a modern practice equipped with Prema where they don't have to wait 3 weeks for a simple consultation, they will move their registration. Furthermore, older practices will completely fail to recruit young, newly graduated doctors. The next generation of medical professionals will simply expect to be working alongside AI tools to manage their workflow.
Within a decade, lacking an AI triage infrastructure will be viewed with the same professional disdain as a practice refusing to use computers for patient records in 2010.
It will become professionally and economically unacceptable to operate without it.
Okay, so we've looked deeply at how this blueprint attempts to solve the immediate domestic crises. The 7 million patient waiting list, the 6.4 billion financial deficit, the vicarious liability trap, and the GP burnout.
We've covered a lot of ground.
But if we pull back and look at the macro ambition of this proposal, fixing the NHS is really just step one.
Right.
The sources propose that the UK can use this exact technology to solve a much larger global existential problem.
Yes. And this loops back to the broader threat of global pandemics and our catastrophic systemic unpreparedness, which the entire world witnessed so clearly with the onset of COVID-19.
The documents pull absolutely no punches when discussing the pandemic response. The core failure was that the UK and the world at large fundamentally lacked a rapid, decentralized early warning system.
We were completely flying blind.
When the novel coronavirus started spreading, we were entirely reliant on passive surveillance.
What does that mean exactly, passive surveillance?
We were waiting for people to get sick enough to go to a hospital. We were waiting for a doctor to decide to take a swab. We were waiting for a centralized lab to process that swab, and then waiting for regional authorities to aggregate the data and report it up the chain.
By the time the World Health Organization or the CDC actually knew what was happening and sounded the alarm, the virus was already everywhere.
It was in every major airport in every city.
That inherent time lag in a passive surveillance system is fatal when you are dealing with the exponential growth curve of a highly infectious respiratory virus.
Because in an exponential curve, days equate to thousands of lives.
This raises the ultimate public health question. How do you detect an outbreak before the patients start overwhelming the intensive care units?
The sources provide a vital, real-world case study regarding the Prema Kiosks that addresses exactly this.
During a localized seasonal influenza outbreak, GP practices equipped with the Prema network identified the epidemic onset 6 days earlier than the traditional national laboratory surveillance systems.
6 days. In epidemiological terms, detecting an outbreak 6 days early is an absolute eternity.
It is the fundamental difference between quickly containing a minor cluster with targeted contact tracing and having to lock down an entire national economy for a year.
And the mechanics of how it detects it so early make perfect sense.
Right.
Because these kiosks are physically out in the community, at the petrol stations, the supermarkets, the pharmacies. They act as a massive real-time sensor network.
Right.
If 50 people in one specific postal code all suddenly walk up to a kiosk on a Tuesday evening complaining of an identical specific respiratory symptom and a high fever.
The AI flags that geographic anomaly instantly.
Exactly. You don't have to wait 2 weeks for the lab results to confirm it. The AI sees the symptom pattern emerging in real time.
Exactly. The kiosk operates not just as a triage point, but as a live, active node in a global healthcare surveillance network.
And the ultimate ambition outlined in these strategic documents is for the NHS to transform from a struggling domestic service into an exportable global standard.
What if the NHS wasn't just a national health service, but the central hub of global health intelligence?
Right, the proposal argues the UK could deploy this Prema AI triage network globally. They can subcontract the manufacturing and deployment of these solar-powered kiosks to developing nations, to rural areas across the globe that currently have zero healthcare infrastructure.
By deploying these units globally, the interconnected system acts as an unprecedented, planetary-scale, real-time sensor network for infectious diseases.
The sources make a highly confident argument that establishing this infrastructure would immediately make the UK the undisputed world leader in managing global healthcare.
They would possess the capability to monitor, map, and preempt global pandemics significantly faster and with more granular accuracy than the World Health Organization currently can.
Because the WHO is fundamentally handicapped by politics and bureaucracy. They rely entirely on data reported voluntarily by individual sovereign countries.
And that data is often incredibly slow, intentionally politicized, or just completely incomplete because the country lacks testing capacity.
Right. An independent, AI-driven kiosk network bypasses all of that. It just looks at the raw, unfiltered symptom data globally in real time. If a novel virus emerges in a remote village, the AI detects the cluster of RAD codes instantly.
And while building this global shield, the business plan notes an incredible economic byproduct. It creates local jobs.
Oh, the kiosk guardians.
Yes, they propose creating roles called kiosk guardians in developing nations. This empowers local micro-entrepreneurs to maintain, clean, and oversee the kiosks, creating a localized economy around the infrastructure while the central AI does the heavy lifting.
It represents a radical, fundamental reimagining of what public health infrastructure looks like in the 21st century. It shifts the entire paradigm away from centralized, reactive, incredibly expensive hospital-based care toward decentralized, proactive, highly accessible, community-based intelligence.
It really is a complete paradigm shift.
So if we take a step back and summarize everything we've unpacked today for you, the learner, we're essentially looking at an ultimate binary choice for the future of how humanity manages its health.
A fork in the road.
Exactly. On one side, we can choose to stubbornly continue down the current path. We stick to traditional, physical, doctor-centered care and the structurally broken NHS 111 triage model.
We force terrified people to wait on the phone, and then we funnel them into crowded waiting rooms.
We know exactly where this path leads mathematically. It leads to a sustained, unmanageable $6.4 billion annual deficit.
It leads to millions of people languishing in suspended animation on waiting lists.
It leads to completely exhausted doctors and a system constantly under the threat of vicarious liability lawsuits.
And most terrifyingly, it leads to hospitals that function not as places of healing, but as highly efficient distribution centers for AMR superbugs.
Superbugs that the data tells us could kill 10 to 16 million people every single year by 2050.
And on the other side of that binary choice, we have the proposed path, aggressively adopting and scaling the decentralized Prema Kiosk model powered by Dr. Maya AI.
It is a model that presents hard data, claiming it can save the NHS £1 billion annually at scale.
It claims it can slash those 7 million person waiting lists by efficiently filtering out the 40% of unnecessary visits at the community level.
It promises to restore dignity and cognitive bandwidth to general practitioners.
And ultimately, it aims to establish a real-time global early warning shield that elevates the NHS to lead the world in surviving the looming post-antibiotic era.
It is a profound pivot point in medical history. We've spent the entire last century operating under the assumption that more healthcare inherently means larger brick-and-mortar buildings.
We thought it meant more crowded waiting rooms, more complex bureaucracy, and more human doctors physically looking at us to tell us we're going to be okay.
But I want to leave you with this thought to mull over. If an artificial intelligence sitting quietly inside a solar-powered steel box at your local petrol station could accurately diagnose a deadly novel infection 6 days faster than a multi-billion-dollar national laboratory.
It really makes you wonder.
We have to ask ourselves a pretty uncomfortable question about the future. Will the survival of the human race in the 21st century depend less on the physical hands that heal us and more on the invisible algorithms that warn us?
A powerful thought to end on.
Thank you for joining us on this deep dive. Stay curious.